Hello, people. Welcome to Pharmacy Medicine. Let's begin with an powerful question. Think your BMI says you're healthy? Think again, because what's hiding is your waistline. Might be far more dangerous than you realize. Recent research show BMI might be underestimating the real impact of excess body weight on health. It's not just about how much fat you carry. It's about where you carry. Fat store around the abdomen is called central fat, and the hidden fat inside organs or muscles known as ectopic fat can silently raise your risk of heart diseases, diabetes, and more, even when your BMI looks normal. That's why health experts now focus on another marker, that is weight circumference. Here is the danger zone. Over 102 centimeters, that is 40 inches in the men, and over 88 centimeters, that is 35 inches in women. That's a red flag for cardiometabolic risk, a silent setup for heart disease, diabetes mellitus, and premature death. But hold on, BMI and waist guidelines are not one size fits all. They may mislead when used for teenagers and the young adults still growing, athletes or muscular individuals, older adults over 65, and notably the racial and the ethnic groups such as Asians, Black, Indigenous Canadians, and the Inuit. So, next time you see a normal BMI, ask yourself, are you really in the clear? Because health isn't just a number. Now, let's see the reality of overweight and obesity. Let's zoom out for a second. Did you know that nearly 74% of the US adults and 40% of the children and the teens are either overweight or obese? That means having a BMI of 25 to 29.9 is considered overweight, and a BMI of 30 or more is obese. But here is where the problem grows. Being overweight increases the risk of coronary heart diseases, high blood pressure, stroke, type 2 diabetes mellitus, and certain types of cancer, and even early death. And beyond the physical risk, it can hurt your quality of life and can lead to social stigma and discrimination. So, what's the solution? It starts with an energy deficit. You either need to eat fewer calories or burn more energy, ideally both. Why? Because that's what forces your body to start burning a fat for a fuel. But here is the catch. If you are constantly hungry, it's nearly impossible to stay on track. That's why many modern weight loss medication focus on increasing the satiety, that means making you feel full, or suppressing the appetite. So remember, BMI is just a number. True health goes deeper. So pay attention to your waistline, know your risk factors, and always look up at the full picture, not just what the scale says. Stay informed, stay empowered, and keep learning with Pharmacy Medicine. Don't forget to like, share, and subscribe for more clear, concise medical insights. Before we jumping into the weight loss treatment, you must ask the right questions. Could the weight gain be from the medication or from an underlying medical condition? So drugs and condition can quietly cause us weight gain in the background. So it is crucial to evaluate and manage them first. Here is the pattern. Weight increases when a medication that causes the weight gain is started, a medication that usually help with the weight loss is stopped, or a condition linked to the weight gain is left untreated. But the weight decrease is when a weight gain causing condition is treated, or you're switching to the medication that helps you with the weight loss. Now, let's see what are the select drugs or condition that can cause us the weight gain. The key drugs includes antipsychotics like clozapine, olanzapine, risperidone, quetiapine, and the diabetic drugs like an insulin, sulfonylureas, meglitinoids, thiazolidinediol, valproic acid, gabapentin, pregabalin, lithium, mirtazapine, steroids, and tricyclic antidepressants like amitriptyline, nortriptyline, and the conditions like hypothyroidism. And the others include the vasodilators like minoxidil, selective serotonin receptor blockers, that is SSRIs like paroxetine. Others may be weight neutral, and MAO inhibitors, hormones like estrogen and progesterone, and beta blockers, estrogen and minoxidil. On the flip side, some drugs can actually help reduce weight, like ADHD drugs like amphetamine and methylphenidate, bupropion, GLP-1 agonists like an exenatide and liraglutide, pramlintide, and roflumilast, SGLT2 inhibitors like canagliflozin and empagliflozin, topiramate, tirzepatide, and the conditions like hypothyroidism, celiac diseases, inflammatory bowel diseases, and the others like lupus erythematosus, tuberculosis, acute disease, GERD or peptic ulcer disease, cystic fibrosis, thyroid drugs like levothyroxine, and the interferons, anti-epileptic drugs like jonissamide, ethosuximide, and the acetylcholinesterase inhibitors like donepezil, rivastigmine, and galantamine. So, how do you tackle the weight gain effectively? According to the American Association of Clinical Endocrinologists, weight loss begins with the personalized meal plan that creates a daily calorie deficit of 500 to 750 kilocalories. DASH diet, low carbohydrate diet, vegetarian, and the volumetric styles. Some patients may even need a very low calories deficit. Now, pair with that with a movement, at least 150 minutes of physical activity per week, spread across 3 to 5 days, include both resistance and the aerobic training. Combine this with an behavioral strategies like self-motivation, goal setting, stress control, social support, and a trained health educators. If lifestyle changes alone don't work, that's when we need to consider a medication, especially in the patients with then weight related conditions like diabetes, hypertension, sleep apnea, or dyslipidemia. And remember, start medication alongside the lifestyle changes, not instead of them. And here is the key: as a patient lose weight, some comorbid may improve, and all meds should be reevaluated and adjusted to avoid side effects like hypoglycemia or hypotension. Now, we are covering the goals of therapy for obesity, along with the two essential phases of the treatment: the induction of weight loss and the prevention of weight regain. This is an ultimate guide for anyone serious about sustainable weight management. Now, let's see the goals of obesity therapy. The primary goal of the obesity therapy isn't cosmetic, it's all about health. Reducing a body weight by 5 to 10% can offer massive health benefits. These include lowering the risk of diabetes, heart diseases, and even some cancers. Here are the core goals. First, reduces the excess body fat for the health benefits, not just appearance. The second one is to stabilize the weight and prevent the further weight gain. And the thirdly, to stop weight regain. And fourth, treat or prevent obesity related comorbidities like hypertension and sleep apnea. Now, let's see the strategies for obesity treatment. Let's face it, there is no one size fits all cure for obesity. It is an heterogeneous condition, meaning that no single approach works for everyone. Emotional, psychosocial, and physical barriers can make adherence to the treatment challenging. Instead of an cure, what we need is a long-term coping strategy. The successful treatment often means dealing with the weight fluctuation, something known as an weight cycling. These periods of remission are followed by relapse. The health risk of these cycles are still debated, but stability remains the ideal goal. The treatment strategies must be holistic, acknowledging both body and the behavior, and that's where the two critical phases of obesity management come in. The phase 1 is induction of weight loss. Phase 1 is all about inducing the weight loss through the caloric restriction. A daily deficit of just 500 kilocalories can result in losing of 1 to 2 kilograms or 2 to 4 pounds every month. Remember this key number: 7,780 kilocalories equal to 1 kilogram of fat. But here is the challenge: you don't want to lose lean body mass like muscle. That's why it is vital to consume high quality of protein and engage in resistant training during this phase. This phase usually lasts for 3 to 6 months or until you hit what all the weight loss plateau, a point where the body resists further weight reduction. Once you reach this point, it's a time to move to phase 2, that is prevention of weight regain. Phase 2 focus on preventing the weight regain, possibly the hardest part of the journey. Why? Because your body hormones and the neurobehavioral system will fight to bring you back to your original weight. And here is the hard truth: these changes don't fade with time. That means long-term caloric control is a must. Even after you hit your goal, consistency is a key. Any slip in your energy intake can result in weight regain. That's why it is crucial to maintain a disciplined diet, regular physical activity, lifestyle changes, and in some cases medication or surgery. These tools can significantly reduce the chances of regaining the lost weight. If this helped clarify your understanding of the obesity treatment, give it a like and share for the more evidence-based health content. Do not forget to hit the bell icon so you will never miss an update on your journey for the better. In part 1, we explored the goals and the phases of the obesity management, from losing weight to preventing the weight regain. Now in part 2, we are diving into the core treatment principles endorsed by the top endocrinology organization. These are the golden standard practice you need to know. First one is dietary guidelines. The American Association of Clinical Endocrinologists and the American College of Endocrinology recommended a range of evidence-based eating plans. These include Mediterranean diet, DASH diet, that means dietary approach to stop the hypertension, low carb and low fat diets, high protein diets, volumetric and vegan diets. Each plan should either create a daily calorie deficit of around 500 to 750 kilocalories or be fully individualized based upon the culture and the personal preferences. Some patients may even qualify for very low calorie diets under the supervision. And the next part is physical activity. When it comes to the movement, the recommendations are clear. At least 150 minutes of the physical activity per week spread across 3 to 5 separate days. That's around 30 minutes per session. And do not forget the resistance exercises like weight training should be done 2 to 3 times weekly to preserve muscle mass and boost metabolism. Exercise isn't just about the burning the calories, it is a powerful tool for maintaining the long-term weight loss and improving the mental health. And the next recommended strategy is behavioral interventions. But what truly makes or breaks weight loss success is behavior. Behavioral interventions are critical and may include self-monitoring of food, exercise and weight, goal settings and accountability, stress reduction techniques, stimulus control like managing the food cues, social support and coaching from the trained professionals. These tools help patient break through the mental and emotional barriers which often sabotage long-term success. Now let's talk medication. Weight loss drugs should only be introduced when lifestyle changes alone aren't enough. They can help in three key areas: inducing a adequate weight loss, maintaining the weight loss, preventing the future weight gain. Patients with an obesity-related diabetes, high blood pressure, sleep apnea, or high cholesterol may start their medication alongside the lifestyle changes. As the weight decreases, these conditions often improve. But remember, medication isn't forever. Treatment needs regular review to avoid side effects like hypoglycemia or low blood pressure. Now, let's see the medication use, which include the prescription drugs and the over-the-counter medications. Many OTC weight loss supplements know worth it. They contain stimulants like bitter orange and or excessive amounts of caffeine, which can be packaged under the different names like herbamate, concentrated green tea powder. OTC supplements are generally ineffective and not recommended as they can be harmful, especially in the patients with then cardiovascular diseases. Now, let's see prescription weight loss drugs. If you or someone you know is considering the prescription weight loss medication, this is your must-watch guide. We are breaking down the most effective drugs and the serious safety precautions you need to know. Not all weight loss medications are the safe for everyone. According to the medical guidelines, here are the key situations where you should avoid with or use with caution. For the all pregnant women, avoid all weight loss drugs. And if the patient is having the high blood pressure, do not use Contrave, which is the brand name for the naltrexone and bupropion hydrochloride. In such cases, use Simia only with the heart rate monitoring. If there is a history of an depression for the patient, Contrave may raise the suicide risk, especially in younger adults and the teens. If the patient is having the seizure disorder, avoid Contrave. It lowers the seizure threshold. Simia, which contain the phentermine and topiramate, should be tapered off gradually. If someone is taking the opioids, Contrave is no go. It blocks the opioid receptor, which can trigger the withdrawal. Now let's see individual drugs in detail. First up is Ximia, that contains phentermine and topiramate as a combination. Phentermine is an sympathomimetic stimulant, releases of norepinephrine, stimulates the satiety center, which decreases the appetite, and the topiramate component increases the satiety and decreases the appetite, possibly by increased GABA and blocking the glutamate receptors and inhibition of the carbonic anhydrase. Ximia is available in modified release tablets. Start with a dose of 3.75 milligram of an phentermine and 223 milligrams of an topiramate once in the morning for 14 days. Maximum dose is 15 milligram by 92 milligram daily. If creatinine clearance is less than 50 ml per minute, maximum dose is 7.4 mg per 46 milligram per day. And the contraindications are pregnancy, glaucoma, MAO inhibitors used within the past 14 days, and hyperthyroidism. The main side effects include CNS effects like insomnia, so that's why it is taken in the morning to reduce the risk, depression, anxiety, suicidal thoughts, headache, paresthesia, tachycardia, vision problems, constipation, dry mouth, and decreased bicarbonate and upper respiratory tract infections, and increased serum creatinine. Taper off due to seizure risk. And the next prescription drug is Contrave, that is naltrexone and bupropion. Naltrexone is believed to decrease the food cravings, and the bupropion decreases the appetite. It is available in modified release tablets. 8 milligram per 90 milligram, that is naltrexone and buspirone respectively. Initially, one tablet per oral every morning, titrate weekly as tolerated. Maximum dose is 2 tablets twice a day. Do not cut, chew or crush swallow as a whole. Fatty acid food increases the drug levels, so do not take with an high-fat meal diet. Contrave carries an boxed warning of for increased suicide risk, especially in the teens and the young adults. It is not approved for major depression, psychiatric illness, and pediatric use. Contraindications include pregnancy, seizures, opioid use, eating disorders, and MAO inhibitors in the last 14 days. And watch out for the side effects like nausea, vomiting, dry mouth, dizziness, insomnia, and increased creatine clearance. And the keynotes here is naltrexone blocks opioids and buprenorphine, which blocks the analgesia and can induce the withdrawal. Discontinue the opioids or buprenorphine 7 to 14 days prior to the use of Contrave. So the weight loss medication can be life-changing, but only when used correctly. Always consult your healthcare provider before starting any treatment. If you found this video helpful, give it a like, subscribe, and let me know the comments if for any doubts. Let's start with another category of drugs, that is GLP-1 agonists. These drugs increases the satiety and slow down the gastric emptying. These glucagon-like peptides, GLP-1 agonists, increases the satiety. First one is liraglutide, that is Saxenda, is used for the weight loss, where the Victoza contain the same liraglutide which is used for the diabetes. Start at 0.6 mg subcutaneously daily for 1 week. Titrate up to 0.6 mg subcutaneously daily at weekly intervals. The target dose is 3 milligrams subcutaneously daily. And other drug in the same category is semaglutide, also known as Wegovy, used for an weight loss, and the Ozempic or the Rybelsus for the diabetes, which contain the same semaglutide. Start at 0.25 milligrams subcutaneously weekly for 4 weeks and then titrate up every 4 weeks. The target dose is 2.4 milligrams subcutaneous weekly. The boxed warnings for this liraglutide and the semaglutide increase the risk of thyroid C-cell carcinomas seen in the animal studies, and the risk to the humans is unknown. These drugs are contraindicated in the person or a family history of medullary thyroid carcinoma or a patient with an multiple endoneoplasia syndrome type 2, that is MEN2. And this Saxenda is contraindicated in the pregnancy. The main warnings include pancreatitis, hypoglycemia, acute bladder disease, gastroparesis, that means a slow gastric emptying, and the side effects are nausea, which is a primary side effect, vomiting, diarrhea, constipation, and injection site reactions. The main keynotes here is may need to decrease the insulin or sulfonyl or meglitine dose to decreases the risk of hypoglycemia. And the next other prescription category of the drug is lipase inhibitor, which decreases the absorption of dietary fats by 30% approximately. And the drug says Orlistat. It is available over the counter and the prescription only medicine. Over the counter product is Ali in the United States, and the prescription drug is branded as an Xenical. Xenical dose is 120 milligram per oral with meal containing a fat. Take with a meal or up to 1 hour after eating. And an OTC drug Ali 60 milligram per oral with each meal containing a fat, and these must be used with a low fat diet plan. And the contraindications are pregnancy, chronic malabsorption syndrome, and cholestasis. And the main warnings include liver damage, which is a rare, cholelithiasis, increased urinary oxalate or kidney stones, hypoglycemia in the patients with an diabetes. Side effects include GI, that is flatulence with discharge, fatty stools, fecal urgency. The keynote here is take multivitamins with A, D, E, K, and beta carotene at the bedtime or separated by greater than or equal to 2 hours. Do not use with an cyclosporin or separate by greater than 3 hours and should be separated with the levothyroxine by 4 hours. Must stick to the dietary plan for both weight gain improvement and to help lessen the GI side effects. Now let's see few appetite suppressants. Mainly sympathomimetics, releases of norepinephrine stimulates the satiety center which decreases the appetite. First one is an phentermine. is available in the tablets as and the dose is 15 to 37.5 milligram daily per orally before or after breakfast or in the divided doses. And the next one is diethylpropion that is available in the immediate release and the prolonged release. The dose of an immediate release is 25 milligram per oral 3 times a day, 1 hour before meals and mid-evening. And the sustained release formulation of this diethylpropion is 75 milligram per oral once at mid-morning. And the other drug in the same category is phendimetrazine, which is also available in the immediate release and the sustained release formulations. Immediate release dose is 35 milligram twice or 3 times a day. That is 1 hour before meals, and the extended release formulation is 105 milligram orally daily, and or it should be taken 30 to 60 minutes before the morning meal. And the final drug in this appetite suppressant category is bensphentamine, that is 25 to 50 milligram per oral daily or TID. Avoid late afternoon administration. Main contraindications for these appetite suppressants are cardiovascular diseases like uncontrolled hypertension, arrhythmias, heart failure, hyperthyroidism, glaucoma, pregnancy, breastfeeding, and the history of an drug abuse. MAO inhibitors within the past 14 days. And the main side effects are tachycardia, agitation, increased blood pressure, insomnia, dizziness, tremors, and psychosis. The main things to be monitored while the patients on this appetite suppressants are blood pressure and the heart rate. These drugs should be used short term up to 12 weeks to jumpstart a diet. The stimulants taken later in the day can cause us the insomnia and potential for misuse or dependence. That wraps on high yield medication for weight loss and a special population. If you found this helpful, don't forget to like, subscribe, and comment GLP-1 gang down below. Follow for more med school pearls and the broad prep hacks. Now let's see the final treatment available for the weight loss. Now we are covering the bariatric surgery pearls, common nutrition deficiencies, and counseling tips for all major weight loss medications, essentially for the USMLE, NAPLEX, and the real world clinical care. The first one is bariatric surgery indication. Let's kick off with an surgery criteria. Bariatric surgery is recommended for the adults with a BMI greater than 40 kilograms per meter square or BMI greater than 35 with an at least one obesity related conditions like diabetes or hypertension. Surgery limits food intake, but long-term success requires the lifestyle changes and the regular exercises. Now is the common nutrition deficiencies. After the surgery of bariatric surgery, nutrition absorption is impaired. Here is what to look out for. The calcium, since it is absorbed in the duodenum, which may be bypassed, use the calcium citrate. It is preferred because it's non-acidic dependent. And there is also an anemia risk. A monitor vitamin B12 and the iron both may need supplementation. Timing tip: take oral and the calcium 2 hours before or 4 hours after the enters, and the patient may need lifelong supplementation of fat soluble vitamins, that's ADEK, due to fat malabsorption. Now let's see medication concerns post-surgery. Medications may require dose reduction and may need to be crushed and put in the liquid or used in the transdermal form for up to 2 months post-surgery. The pharmacist need to assess which drug can be safely crushed and provided alternatives to the drug that cannot be crushed, that is like extended release formulations. The rapid weight loss can cause us the gallstones. The urcidiol or urso 250 or urso 4 dissolves the gallstones and may be needed unless the gallbladder has been removed. And key counseling points include all weight loss medications can improve diabetes and hypertension. So monitor these conditions closely. Dose reduction may be needed for medications. The main counseling point for the phentermine or tropyramide, that is Ximia, is take these medications in the morning. Avoid taking this medication in the evening to prevent the insomnia. And the phentermine can increases the increased heart rate, so monitor it regularly. And the key counseling points for the naltrexone or bupropion, that is Contrave, is do not take this with opioids or with an history of seizures, can causes increased blood pressure. And the counseling points for the GLP-1 agonists are these are subcutaneous injection, can cause us the pancreatitis, nausea, and hypoglycemia. So do not take with an other GLP-1 agonist used for the diabetes. Last but not the least is Orlistat, which is branded as an Xenical and Ali over the counter. Take one capsule at each main meal or up to 1 hour after a meal that contains fat. You should be eating a healthy diet that is low in the fat in order to reduce the GI side effects. This can cause us the stomach issues like fatty or oily stool, oily spottings, intestinal gas with the discharge. Need to have a bowel movement right away. Increased number of bowel movements or poor bowel control. And the appetite suppressant can cause us increased blood pressure and the increased heart rate. And these should be used short term only and monitor the vitals. So, and that wraps up our deep dive into the obesity management. We have uncovered the BMI is just one piece of a puzzle. Its complications like diabetes, hypertension, and heart diseases that truly raise the stakes. We looked at non pharmacological strategies like diet, exercise, behavioral modification, and the true foundation of any weight loss journey. And we explored both over the counter options and the prescription weight loss medications, their dosing, side effect, contraindications, and the key role of the patient counseling. Remember, these are not magic pills, they are tools to use wisely and only when appropriate. And for those with an severe obesity or a failed medical therapy, bariatric surgery remains a proven, a life changing option. The weight management is not a one size fits all journey. It's about personalized care, consistent follow up, and setting a realistic goals. So stay informed, stay committed, and always work closely with your healthcare provider. If you found this video helpful, don't forget to like, share, and subscribe for the more clear, concise medical content made easy. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.